Hi everyone, welcome back. This is part 2 of the video series on anemia. In this video, you're going to learn about the microcytic anemias. Let's get started. Okay, so in video 1 of the series, we started talking about what anemia is, and we introduced this diagnostic algorithm. So as a quick refresher, anemia is a decrease in the red blood cell mass, and it's diagnosed by a low hemoglobin and hematocrit on a CBC. So this is the key lab value here, a low hemoglobin and hematocrit equals anemia. But once we find this, we're not done, because now we have to figure out what caused the anemia, and there are many different diseases that cause it. So we use a diagnostic algorithm to help us narrow the differential diagnosis, and this algorithm uses the MCV of the red blood cells. So diseases that cause anemia with low MCV are going to be put in this bucket of microcytic anemia. Those with normal MCV are going to be in this bucket of normocytic, and finally those with high MCV are going to be in this bucket of macrocytic. And in this video, we're going to explore those with the low MCV macrocytic anemia. Okay, so MCV is short for mean corpuscular volume. So it is the average volume or size of someone's red blood cells, and the normal range for this is 80 to 100 femtoliters. So in microcytic anemia, which is our topic for today, the MCV is below 80. That means that red blood cells are smaller than this range. So microcytic anemia is defined as anemia when the MCV is less than 80 femtoliters. And the underlying mechanism of microcytic anemia, regardless of whichever disease is causing it, is decreased hemoglobin synthesis. So if there's just one thing I want you to take away from this entire video, it is that from now on and forever, remember that the underlying cause of any microcytic anemia is always going to be a decrease in hemoglobin synthesis. Okay, so you might be wondering, why is decreased hemoglobin synthesis the cause of microcytic anemia? In other words, how does making less hemoglobin lead to smaller red blood cells? Well, here's why. Red blood cells are generated in the bone marrow from a progenitor cell. They're going to undergo several rounds of division, and with each division, they're going to get smaller until the hemoglobin concentration inside of the cell is high enough to reach what's called a critical level. And then once this happens, then it can get released into the blood. It's going to become one of our circulating red blood cells, and normally the size at this stage is around 80 to 100 femtoliters. But when we have a disease that causes decreased hemoglobin synthesis, then by definition, the hemoglobin concentration inside of the red blood cell is going to be less than normal because we're synthesizing less. So in order to hit that critical hemoglobin concentration for release, the only thing the cells can do is to reduce their volume. So they're going to undergo an extra division step, which is going to reduce their size. And now the hemoglobin concentration is high enough that they can be released. But this extra division means their size is now smaller than normal, so less than 80 femtoliters. And this is why decreased hemoglobin synthesis is the underlying mechanism for microcytic anemia. Okay, so we established that microcytic anemia equals decreased hemoglobin synthesis. Now let's start learning what are the diseases that cause this. So hemoglobin is composed of two parts, heme and globin chains, and heme itself is made up of iron and protoporphyrin, and globin is made up of alpha and beta chains. So what this means is that microcytic anemia is from either a decrease in heme synthesis, which could be from a decrease in iron or a decrease in protoporphyrin, or a decrease in globin synthesis, which could be from a lack of either the alpha or the beta globin chains. So any disease that causes microcytic anemia has to fall into one of these categories right here. And there are 5 main diseases that cause microcytic anemia, and the mnemonic for them is TAILS, which stands for thalassemia, anemia of chronic disease, iron deficiency anemia, lead toxicity, and sideroblastic anemia. One little caveat is that anemia of chronic disease and iron deficiency can not only cause microcytic anemia, but they can also cause normocytic anemia. So keep that in mind, that these two conditions can cause both micro and normocytic anemia. But with that said, let's run through this list and learn about each of these 5 causes of microcytic anemia. Okay, I'm going to start with the letter I in our mnemonic, which is iron deficiency anemia. Iron deficiency anemia, or IDA, is the #1 cause of anemia in the US and the world. The problem is that there's a low amount of total iron in the body, which means that the red blood cells have less iron, which means they can't make heme, which means they can't make hemoglobin, and by now you know that that means microcytic anemia. Okay, so then what are the causes for the body to be low in iron? You can think of it in terms of either decreased intake or absorption, or increased demand or loss. So let's start with decreased intake from the diet. This is due to malnutrition or vegetarian diets, or in infants that are exclusively breastfed without any iron supplementation. Decreased absorption is when you have a problem with the GI tract, so you're eating enough iron but you just can't absorb it into the body, and common causes can be celiac or other intestinal diseases, surgeries such as gastrectomy, and then also, since vitamin C is important for absorption of certain types of iron, vitamin C deficiency can also lead to iron deficiency due to problems with its absorption. Increased demand usually occurs in childhood due to growth. Also in pregnancy, this is a very important and common cause of iron deficiency anemia. And then finally, patients who have chronic hemolytic diseases are going to have an increased demand for iron because they're constantly breaking down and hemolyzing red blood cells. So they need more iron to be able to replace those red blood cells. And so they can actually get a secondary iron deficiency anemia from their hemolytic disease. And then finally, increased loss occurs in the setting of chronic blood loss. This is the only way that we lose iron from our body. And the most common thing that we see clinically is due to heavy menses, but you should also keep in mind that you can have a slow occult bleeding in the GI tract, for example, in the setting of colon cancer. So this is a can't miss diagnosis that you have to consider. Now let's talk about the symptoms of iron deficiency anemia. So all anemias are going to have symptoms of tissue hypoxia, which is shortness of breath or fatigue, but there's a couple of symptoms that are more unique to iron deficiency anemia that you don't get to see in other anemias, so it's helpful to know them. One of them is koilonychia, which is spoon-shaped nails, and the other one is pica, which is the craving of substances that are not nutritive or food. The most common case here in iron deficiency anemia is craving ice. Okay, so now let's say you have a patient that you're suspecting iron deficiency anemia. How are you going to make the diagnosis? The most important test is going to be the iron studies. This is the one that's going to give you definitive diagnosis. What it's going to show you is since your total body iron is low, the serum iron and the ferritin are both going to be low. And since the ferritin is low, the TIBC is going to be high because they always go opposite. And since the serum iron is low and the TIBC is high, then the percent SAT is going to be low. And if you've watched my video on iron studies, then you already knew this. If you haven't had a chance yet, I'll link it at the end of this video so you can check it out. I think it'll help you a lot. Now, besides iron studies, there's a couple of other findings. On the peripheral blood smear, you're going to see hypochromia. Hypo means less, chromia means color. So this literally means that these red blood cells are going to be pale with an increased zone of pallor. And you can see that when you compare the red blood cells on this hypochromia smear with this one with a normal red blood cell smear. And the reason for this is because of less hemoglobin inside those red blood cells. So all microcytic anemias, not just iron deficiency, but all of them are going to have hypochromia because they all have less hemoglobin. But on test questions, it's usually used in the setting of IDA. So just keep that in mind. The other important clues are in the labs. So you can get an increased RDW. RDW stands for the red cell distribution width, and this is basically just the range of the red blood cell sizes in a person's blood. And since in iron deficiency anemia, the red blood cells usually start off as normocytic and get smaller as the disease progresses, this is going to create a wider range, and that's why it's going to have a high RDW. The other test that's going to be helpful as a clue is going to be a high protoporphyrin level inside of the red blood cells. Normally, protoporphyrin binds iron to form heme, but there's no iron around to bind, so protoporphyrin is just going to hang out unbound, so the free levels are going to be elevated. And now finally, let's talk about the treatment. So once we've made a diagnosis, how are we going to treat iron deficiency anemia? And there's basically just three things to consider. Number one, of course, is going to be to have the patient take iron. Most commonly, they can take it orally, but in more severe cases, we can also give iron infusion IV. If the anemia is really severe, then we can actually transfuse them with red blood cells to fix the anemia right away. And then finally, this is the most important one that I want to stress. It's not just enough to treat the iron problem and the anemia, but you have to figure out why is this patient iron deficient, because in many cases, for example, in colon cancer, iron deficiency anemia is literally the first presenting clue that the patient has an occult cancer. So once you recognize iron deficiency anemia, you can't just stop there. You have to go and work up the patient to figure out the cause of the iron deficiency and rule out serious causes. All right, and let's finish with one final thing about iron deficiency anemia. This one is a very rare condition clinically, but it does show up on board exam questions. It's called Plummer-Vinson syndrome. It's a classic triad of iron deficiency anemia, esophageal webs, which are thin membranes in the esophagus that can cause obstruction, and dysphagia, which is difficulty swallowing, which is caused by those esophageal webs. Now, the exact linkage of the iron deficiency anemia isn't clear here, but it's thought that the anemia is more likely the cause of these esophageal problems, not the consequence. So in other words, someone has long-standing and severe iron deficiency anemia, and this severe lack of iron in the tissues of the esophagus causes there to be thinning membranes and weakened esophageal muscles, which is then going to lead to the formation of the webs and the difficulty swallowing. Lack of iron can also damage the cells of the mucosa of the mouth, so it can cause atrophic glossitis, which is inflammation of the tongue, or angular cheilitis, which is inflammation of the angles or corners of the mouth. And then finally, it's important to recognize that Plummer-Vinson syndrome is associated with an increased risk of squamous cell carcinoma of the esophagus. Okay, so now let's talk about anemia of chronic disease, and you can tell from the name that this anemia is caused by chronic diseases. The main ones are autoimmune diseases like rheumatoid arthritis and lupus, as well as cancer. Also, some chronic infections like TB and endocarditis can do this. So why do these diseases cause anemia? What is the connection? There are two main mechanisms. The first one is pretty straightforward. For reasons that aren't entirely clear, there's decreased EPO production by the kidney, as well as decreased response to EPO by the bone marrow in these chronic diseases. And EPO is the main hormone that stimulates red blood cell production. So when there's a decrease in its action, that's going to mean that we're going to have less red blood cells, and so anemia. The second mechanism is very, very important and high yield for exams. So when we have chronic diseases, our body is going to have systemic inflammation chronically, and therefore we're going to have high levels of cytokines as a result of this inflammation, especially interleukin-6. Interleukin-6 is going to stimulate high levels of hepcidin. Hepcidin is a peptide hormone that's made by the liver, and it is the main regulator of the levels of iron inside the body. What hepcidin does is it causes iron to be trapped inside of the macrophages in the liver. When iron is trapped there, it can't circulate the blood, and it can't make it to the bone marrow to get to the red blood cells that need it. Therefore, those red blood cells are going to sit there and wait for iron. They're never going to get it. Since they don't have iron, they can't make heme. Since they can't make heme, they can't make hemoglobin, and therefore we're going to get microcytic anemia. So it's very important that you know the role of hepcidin, which is to trap the iron inside of the liver macrophages. I like to keep this little rhyme that I made. Hepcidin keeps the iron hidden inside the macrophages of the liver away from red blood cells, and that's the problem here. So the diagnosis here is going to be with iron studies, and this is what you're going to use to differentiate this condition from a patient that has iron deficiency anemia, because these iron studies are going to be a little different. So the serum iron is going to be low because the iron is trapped inside of the cells. It's not in the blood. The ferritin, though, in this case is going to be high because you have high intracellular stores of iron, and that's what ferritin is measuring, and this is what's different compared to the iron deficiency anemia. Since ferritin is high, TIBC is going to be low because they always run opposed to each other, and since both iron and TIBC are low, then your percent stat is going to be normal or only slightly decreased. And then finally, the treatment of this is going to be to treat the underlying disease, so the autoimmune condition or cancer or chronic infection, as well as give EPO injections in certain cases. Okay, so before we move on to the other causes of microcytic anemia, let me recap iron deficiency anemia and anemia of chronic disease real quick. So in both of these cases, we have anemia because their red blood cells lack iron to make heme. But in iron deficiency anemia, the reason for this is that the entire body is low in iron. That's why we have iron deficiency. However, in anemia of chronic disease, the body is not deficient in iron. In fact, we have plenty of iron, but it is trapped inside of the macrophages due to the high levels of hepcidin, and that's the key difference between these two. And finally, you may be wondering, why would the body react in such a way to chronic disease by keeping the iron trapped inside of macrophages? Is there a reason for it? Well, there actually is. It's thought that this persistent inflammation and high levels of cytokines might be tricking the body into thinking that it's fighting off a bacterial infection. And so the body decides to keep iron stored inside of its own cells to keep it out of the circulation and away from bacteria that can use iron for their advantage and pathogenicity. So it's actually thought that this might have been designed as a protective mechanism that has harmful consequences, causing anemia of chronic disease. Okay, so now let's talk about lead toxicity and sideroblastic anemia. And in order to talk about those, we need to first understand how heme synthesis occurs. So heme synthesis occurs inside the red blood cell precursors in the bone marrow. And remember that heme has two components. It has iron and protoporphyrin. And the iron we obtain from the diet, but the protoporphyrin has to be synthesized inside of these red blood cell precursors. And the way that it does so is in a series of steps right here. And there are really three key steps and enzymes that you need to know. Step 1 is succinyl-CoA coming together with glycine to form ALA, and this is mediated by the enzyme ALA synthase. And then ALA gets converted to porphobilinogen in step 2, and this is mediated by the enzyme ALA dehydratase. And then there are several other reactions that are going to go on after porphobilinogen until it finally becomes protoporphyrin. And then the final step of heme synthesis is that protoporphyrin and iron have to come together to form heme, and this is mediated by the third and final key step enzyme, which is ferrochelatase. So these are the three key enzymes that we need to know, because these are the three that are going to be problematic in lead toxicity and sideroblastic anemia. So in both lead toxicity and sideroblastic anemia, there's a defect in one of these enzymes in heme synthesis. In sideroblastic anemia, the enzyme that's problematic is ALA synthase, or ALAS, which is the first enzyme. So in sideroblastic anemia, we have an ALA synthase deficiency, and this is going to lead to decreased protoporphyrin levels because we cannot synthesize protoporphyrin because step 1 is inhibited right here. In lead toxicity, on the other hand, the other two enzymes are affected and inhibited by the lead poisoning. Those enzymes are ALA dehydratase and ferrochelatase, and as a consequence of inhibition of enzymes, their substrate is going to build up. So in lead toxicity, you can have high levels of ALA because ALA dehydratase is inhibited, and you can have actually high levels of protoporphyrin because ferrochelatase is inhibited. And here's a little mnemonic on how you remember ALAS versus ALAD. ALAS ends with S as in sideroblastic anemia, and ALAD sounds like a lead, so ALAD for lead toxicity. All right, so now let's start learning about each of these separately. Let's start with sideroblastic anemia. The terminology here can get a little confusing, so let me explain. Sideroblastic anemia isn't just one condition, it's actually a group of different disorders that inhibit heme synthesis enzymes, and they lead to two things happening. Number one, anemia, and number two, formation of something known as ringed sideroblasts, and that's why this is known as sideroblastic anemia. So what happens is that when these diseases inhibit heme synthesis, that means that the iron inside of those red blood cell precursor cells is now no longer being used up to make heme, so it's going to deposit in the mitochondria. It's going to form in the shape of a ring, a bunch of iron deposits in the mitochondria, and that's what you're going to see as these ringed sideroblasts. So let's take a look at this picture right here. We're looking here in the bone marrow because that's where the red blood cell precursor cells are, and we know that that's what we're talking about because these are blasts, which are precursor cells in the bone marrow. And if you take a look right here, you see that there's a bunch of blue granules distributed in a ring-like fashion. These are the iron deposits in the mitochondria. And so the term ringed sideroblast, the ring describes the shape, sidero means iron deposits, and the blast describes the fact that these are precursor blood cells that are found in the bone marrow. This is a hallmark finding for sideroblastic anemia. For causes of sideroblastic anemia, we have congenital, which is the one that we talked about, the ALAS or ALA synthase deficiency. This is an X-linked defect, and this is going to lead to low levels of protoporphyrin because we're essentially inhibiting step one of protoporphyrin synthesis. But there are also acquired causes of sideroblastic anemia, right? Things that can inhibit heme synthesis enzymes, for example, B6 or copper deficiency, because these guys are needed for those heme synthesis enzymes to work. Some meds can poison those enzymes and cause them to stop working. And then finally, lead toxicity. Even though we're talking about lead toxicity in the upcoming slides as a separate pathology and part of the TALES mnemonic, at the end of the day, it's just another process that's inhibiting heme synthesis enzymes, so it's going to also cause anemia and the formation of ring sideroblasts just by inhibiting different enzymes than the congenital form, which is what we're talking about here. For USMLE, most of the time, if they just say sideroblastic anemia and don't give you any specifics, they're most likely just talking about the congenital X-linked defect of ALAS. To make the diagnosis, we get iron studies, and as you can imagine, the iron studies are going to show an iron overload state because the iron is not being used up to form heme. So high serum iron levels, high ferritin levels, which are the intracellular forms of iron. If ferritin is high, then TIBC is low. And then finally, if we have high iron and low TIBC, then percent saturation is going to be elevated. And then finally, to clinch the diagnosis, we get a bone marrow stained with Prussian blue. Prussian blue stains iron blue, and that's what we're seeing right here. And it's going to show the formation of the ringed sideroblasts, which are the characteristic finding of this condition. Okay, so now let's move on to lead toxicity. Lead is a readily absorbed heavy metal, and the poisoning is almost always chronic. Exposure is through things like paint. Think about older homes and children eating paint chips. Recreational, some people make illegally distilled alcohol called moonshine, and those containers can be contaminated with lead. Occupational, so think of batty industrial workers. And then finally, contamination, such as contamination of water from lead from factories. The problem with these poisonings is that they're not going to just affect one single part of the body. They're going to be systemic because this toxin is going to go everywhere. So lead has classically effects in many different organ systems, and here are the main ones. So hematologic, we already talked about. It causes microcytic anemia by inhibiting ALAD and ferrochelatase. It can also damage the kidneys, especially the proximal tubules, and cause renal failure. Skeletal system, it can cause growth plate remodeling in children, and there's some characteristic finding on x-ray that I'll show you on the next slide. Gastrointestinal tract, it can cause problems with severe, poorly localized abdominal pain, again, especially in kids. This is known as colic, and this is especially high yield on board exams. If you have a kid who has abdominal pain and all the workup has been unremarkable and it's chronic, pay attention for lead toxicity, especially if they have anemia. And then finally, the most devastating one is neurologic. In children, it tends to affect more the central nervous system. It can cause reduced IQ, seizures, psychiatric conditions, coma, and death. In adults, it primarily affects the peripheral nervous system. It causes demyelination, and high yield for exams is wrist and foot drop, because these are commonly used muscles, as well as polyneuropathy. So again, very high yield for exams, wrist and foot drop should make you think about lead toxicity, especially if the person has microcytic anemia. In lead toxicity, there are clinical findings that are called lead lines, and there are two different types of these lead lines. The first ones are in the gums. They're also known as gingival lead lines or Burton lines, and these are caused because the lead is going to react with sulfur ions, which are made by the mouth bacteria, and this reaction is going to form lead sulfide, which is visible right here at the margin of the gums and has this blue purplish pigment color. The other lines are called bony lead lines, so obviously these are in the bone, and so these are only seen on x-ray when you're looking at bone. And what happens is that lead inhibits osteoclast remodeling of bone but has no effect on osteoblasts. So the affected bone is going to be more dense, and so the metaphysis of these growing bones next to the growth plate is going to look radio-opaque, which means it's going to be more bright white, and you can see the line of bright white right here along the tip of the arrow. This is a bony lead line. And then finally, there's a good mnemonic for the main symptoms of the toxicity, and it actually is the word lead itself. So L is lines, which are the gingiva and bone lines. E is for encephalopathy, so don't forget the CNS problems, especially in kids. A is for anemia due to impaired heme synthesis, as well as abdominal for the GI tract symptoms. And then finally, D is for drop, which is the wrist and foot drop, and peripheral neuropathy. Okay, so how do we make the diagnosis of the toxicity? We can check blood lead levels and they would be elevated. We'd also expect high levels of protoporphyrin in red blood cells, and that's because ferrochelatase is often inhibited, which is going to lead to buildup of its substrate, which is protoporphyrin. Bone marrow biopsy is going to show the ringed sideroblasts instead of the normal erythrocytes for the reasons that we mentioned earlier. Heme synthesis is inhibited, therefore iron is going to build up inside the mitochondria and those red blood cell precursor cells and form this ringed shape. And but the more high yield thing to know as far as on any kind of smears or staining is on the peripheral blood smear, so not the bone marrow, but the actual peripheral blood. When that's smeared, there's a finding called basophilic stippling, which is shown right here where the arrows are. This is a good example of one right here where the cursor is. So this basophilic stippling, basophilic means blue and stippling means granules. So this is basically blue granules that you're going to see throughout the cytoplasm of these red blood cells. And these are actually little ribosomal precipitates. And these happen because the normal process of red blood cell maturation is disrupted due to the poisoning. So these red blood cells can't completely clear out their ribosomes, and it's going to be left in there, and you're going to see that on the peripheral blood smear. Now, this basophilic stippling is not specific to lead toxicity alone. It's actually seen in many other conditions where normal red blood cell processes are disrupted, like thalassemia and alcohol abuse. But for the purposes of board exams, they often show this in association with lead toxicity. So you should keep this basophilic stippling in mind for lead toxicity. And then finally, the treatment for lead toxicity is chelation. So lead is a heavy metal, and whenever we want to remove heavy metals, we give sequestering agents that bind those metals and eliminate them from the body, and this is known as chelation. And the common chelators used for this are succimer, EDTA, and dimercaprol. Okay, so before we move on to our final cause of microcytic anemia, which is going to be the thalassemias, let's recap sideroblastic and lead toxicity. So in both of these, the problem is that there's a decrease in the activity of heme synthesis enzymes. In sideroblastic anemia, which we're considering as the congenital form, there's an X-linked elast deficiency, whereas in lead toxicity, the problem is inhibition of elad and ferrochelatase due to poisoning by excess lead. Okay, so now let's move on to our final cause of microcytic anemia, which is thalassemia. Remember, thalassemia is different than all the other ones we've talked about because in thalassemia, the problem is decreased globin synthesis. So there's nothing wrong with iron or heme. The problem is going to be the globin chains. And just to make sure everyone's on the same page, I'm going to first explain the different types of globin that make up normal hemoglobin. So in humans, there are normally 3 types of hemoglobin. They all have 4 subunits. 2 of them are always going to be alpha, and the other 2 are the difference makers. So in fetal hemoglobin, which is hemoglobin F, the 2 alpha chains are paired up with 2 gamma chains, and this is called fetal hemoglobin because it's the main hemoglobin in the fetus. Then we have hemoglobin A, also called hemoglobin A1, and here the 2 alpha chains are paired up with 2 beta chains, and this is called hemoglobin A or A1 because it's the most common type in the adult period. And then finally there's hemoglobin A2. In this one, the 2 alpha chains are paired up with 2 delta chains, and I'm guessing that this one is named A2 because it's only a minor contributor and much less common than hemoglobin A1. So what this all means is that if we do a hemoglobin electrophoresis to check out all the different types of hemoglobin we have, this is what we would see under normal conditions. During the entire fetal period and even after birth up until around 6 months of age or so, most of the hemoglobin in the body is going to be fetal hemoglobin, which is alpha 2, gamma 2, and only a small fraction is going to be hemoglobin A. But in the adult period, which is pretty much everything after 6 months of age, the main hemoglobin type is going to be hemoglobin A, which is made up of 2 alpha and 2 beta chains. There's a small amount of hemoglobin A2, which is alpha 2 delta 2, and a tiny fraction of hemoglobin F, but normal adult hemoglobin is almost entirely hemoglobin A, which is made up of A alpha and beta subunits. And so now that you know this normal globin chains, let's see how these are going to be different in thalassemia. All right, so let's talk about thalassemia. This is the T in our tails mnemonic. The problem with thalassemia is an inherited mutation. It's autosomal recessive, and the gene is either the alpha or the beta globin chain gene. So what's going to happen is that we're going to have decreased production of the globin chain, either alpha or beta. This is going to lead to decreased hemoglobin, which, as you know, is going to cause microcytic anemia. One thing that students often mix up is the difference between thalassemia and sickle cell anemia. In thalassemia, we have a decrease in the production of the globin chain. So we have decreased hemoglobin. This is a quantity problem, so it's going to cause microcytic anemia, whereas in sickle cell anemia, we don't have a decrease in the amount, we have production of abnormally shaped hemoglobin, and so this is a quality problem, and this is going to cause normocytic anemia, and I'll explain and go through sickle cell anemia in the separate videos in under normocytic anemia. But for now, let's focus on thalassemia and talk about the difference between alpha versus beta thalassemia. Okay, so let's start with alpha thalassemia. The problem here is with the alpha globin chain. That's why this is known as alpha thalassemia. And the alleles for the alpha globin chain are on chromosome 16, and there's actually 4 alleles. So there's 2 on each copies of chromosome 16 for a total of 4. So a normal genotype would be alpha, 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 as shown here in this picture. So now let's talk about the symptoms associated with alpha thalassemia, and let's go through it because it depends on how many of these 4 alleles are deleted. So the top row right here is alpha, 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 so this is basically normal. There's no thalassemia going on here, so obviously no symptoms. If there's one of the alleles that are deleted, then we have what's called a silent carrier because this person still has plenty of genes to produce enough alpha globin chains, so no symptoms. If 2 are missing, both alleles could be missing from the same chromosome or one allele from each copy of the chromosome. Either way, this is called alpha thalassemia trait, and that's because these patients are either asymptomatic or only have mild anemia. That's because they essentially still have 50% functional capacity of their alpha globin chain, so they'll be fine. The ones that are going to be the problem are these last 2 right here. So if 3 out of the 4 alleles are deleted, this is very, very severe anemia. This is called hemoglobin H disease. Hemoglobin H is when you have beta globin tetramers, and these guys form because there's very little alpha around, so the beta globins are going to form tetramers. The problem is that when the beta globin form tetramers, they're actually going to precipitate inside those red blood cells and cause hemolysis and make the anemia even worse. So these patients are going to have severe anemia and are going to require very frequent red blood cell transfusions to help treat their symptoms. And then the final one is if all 4 copies or all 4 alleles are deleted, then this is basically going to cause fetal hydrops, which is a severe high output heart failure in the fetus caused by this profound anemia, and this is going to cause death in utero. And the abnormal hemoglobin that's produced here is hemoglobin Bart's, and hemoglobin Bart's is formation of gamma tetramers, and that's because in the fetal period we don't have beta yet, we have gamma. So since there's no alpha around, the gammas are going to form tetramers, and basically there is no functional hemoglobin at all for the fetus, so it's unfortunately going to cause severe problems, hydrops fetalis, and death in utero. Okay, so let's move on to beta thalassemia. The problem here is with the beta globin chain, and remember the gene is on chromosome 11, and unlike alpha, there are only 2 alleles here for beta, so 1 on each copy of chromosome 11, so our normal genotype is going to be beta/beta. The other important thing that's different than alpha thalassemia is that the symptoms of beta thalassemia are not going to show up in the fetus. And in fact, they probably won't show up until after 6 months of age. And that's because up until then, we primarily use what's called fetal hemoglobin, which is made up of alpha and gamma. So a beta deficiency is not going to affect that. So this is a very high yield and important fact to know about the difference between beta and alpha thalassemia, that for beta, it doesn't show up until after 6 months of age or so. So now let's move on to the types. And first, here is the key to the alleles, because this is important to know to interpret this. So when you see just the letter beta by itself, that means this is a normal allele. When you see it with a little plus sign, that means that the mutation is causing a decrease in the function of that allele, so it's going to cause less beta globin to be made from that gene. And then when you see it with a little 0 next to it, that means that the mutation is causing a complete loss of function of that allele, so that nothing is going to be made, no beta globin is going to be made from that gene right there. Okay, so now let's look at the symptoms right here, and there are three disease categories. The first one is thalassemia minor, and the genotype here is going to be beta with either a beta plus or a beta 0. So either way, there's at least one normally functioning allele, so a decent amount of beta globin chain is still going to be made, and so this patient is going to have either no symptoms or only mild anemia. And on their hemoglobin electrophoresis, we're going to see a mild decrease in the normal hemoglobin, which is hemoglobin A, and a mild increase in hemoglobin A2 to make up for a little bit of that loss of the beta globin chains. The next one is the medium severity. So this is thalassemia intermedia. And here, both copies of the gene are going to have some abnormality. So the genotype is going to be beta plus with either another beta plus or with a beta 0. So either way, there's at least one beta plus, which means that some beta globin is going to be made. So we don't have a complete absence of beta globin, but it's still a pretty significant loss of it. So these patients are going to have pretty significant symptoms and at least moderate to severe anemia. And then the final category here is going to be the most severe or the most major. That's why it's called thalassemia major. And so here, both copies of the gene are beta 0, so they make no beta globin. So this patient is going to have severe anemia and is going to need very frequent red blood cell transfusions. And on hemoglobin electrophoresis here, we're going to have no hemoglobin A because we have no beta globin. And instead, we're going to have high levels of hemoglobin A2 and fetal hemoglobin because the alpha globin chains are going to link up with the delta and gamma chains instead. Okay, so now let's talk about the clinical features that are high yield associated with thalassemia, and there are four major categories of complications here to keep in mind. So number one, we have decreased globin chain, either alpha or beta, which is going to cause underproduction of hemoglobin, which is going to lead to microcytic anemia. This is going to be the key tip-off. Number two, because of the abnormal globin chain tetramers that can form, these can cause hemolysis of the red blood cells as they filter through the spleen, and this is going to cause three separate issues. Number one, this destruction of the red blood cells is going to further exacerbate the anemia. Number two, the spleen is also going to get congested by all the breaking down of the red blood cells, which is going to cause it to enlarge in size, and this is called splenomegaly. And then finally, there's going to be a large rise in the bilirubin because it's a byproduct of heme breakdown, and the high bilirubin levels are going to cause jaundice as well as can lead to formation of pigmented gallstones. Now, number three, we're going to have something known as erythroid hyperplasia to compensate for the severe anemia. Erythroid refers to the red blood cell precursors, and this means that they're going to proliferate or undergo hyperplasia to make new red blood cells in response to our severe anemia. And these red blood cell progenitor cells are mostly in the bone marrow. So classically, hyperplasia is going to cause these patients to have thickening of some of their bony structures. Most apparent is going to be prominent skull and facial bones. The red blood cell progenitor cells are also going to be found outside of the bone marrow, and they can rev up production there as well. So this is called extramedullary, meaning outside the bone marrow, hematopoiesis. And the two main locations for this are the liver and the spleen. So this is going to cause enlargement of these two organs, which is known as hepatosplenomegaly. So now we have two reasons for the spleen to be enlarged and undergo splenomegaly. And then the final complication is actually iatrogenic, meaning it's caused by the medical treatment of thalassemia. So most patients with severe thalassemia are going to require frequent red blood cell transfusions. And since these red blood cells are also containing iron, these patients are going to end up developing iron overload secondary to the blood transfusions. And this is known as secondary hemochromatosis. And this is a problem because this excess iron can deposit in the different organs like the liver, heart, skin, and pancreas and become toxic. Okay, so now let's talk about how to diagnose thalassemia. There are some clues here that can help. So first, this is an inherited autosomal recessive condition, so family history might be positive for thalassemia in that autosomal recessive pattern. Second is ancestry. So thalassemia is more prevalent in areas where malaria is endemic. It's thought that that's because the thalassemia mutation can actually protect against malaria, and this is going to lead to an evolutionary pressure for that mutation to have survived in those regions. So generally speaking, alpha thalassemia is more common in people of Asian and African descent, whereas beta thalassemia is more common in those of Mediterranean descent. Now, I want you to be careful of just trying to use this as the only way to make the diagnosis. Just because someone has an ancestry from one of these regions and they have anemia doesn't mean that this is caused by thalassemia. And also, on the other hand, just because someone doesn't have this ancestry doesn't rule out thalassemia. And test makers actually know that students have memorized this association, so sometimes they may try to trick you by giving you an ancestry in a test question that is not relevant. So the bottom line with this ancestry is that you should know this association, but don't use it as the only basis to rule out or in thalassemia. Another clue is the RDW, which is the red blood cell distribution width. Basically, it's a measure of the variation in the size of the red blood cells in a person. So in iron deficiency anemia, which is another major cause of microcytic anemia, this RDW is going to be elevated, and that's because the cells are going to start off first as normocytic at baseline, and then gradually they're going to get smaller as there's less and less iron, so there's going to be a wider range or variation in their size. In thalassemia, on the other hand, the RDW should generally be around the normal range, and it should be less than iron deficiency anemia, so it shouldn't be elevated. That's because thalassemia is an inherited genetic condition. So all the red blood cells in that person are pre-programmed to start off with the same mutation that causes them to be small, so there should not be a wide range or variation among their sizes. And then the final clue is going to be in the peripheral blood smear. You might find something called target cells, and here's an example of one on a smear right here. It's basically just a dark central spot that makes this look different than normal red blood cells and makes it look like a target. This is not specific to thalassemia and can occur with many other diseases, although on many test questions it's used in association with thalassemia, so you should just keep it in mind. Now, to actually confirm the diagnosis of thalassemia, we have two good tests. The first one is hemoglobin electrophoresis. So you can check out the patient's hemoglobin, and you would expect to see low levels of the normal hemoglobin A and elevated levels of the other types. And then you can also do DNA analysis in some cases to confirm the diagnosis and identify the specific genetic mutation. So let's wrap up by learning about the treatment of thalassemia. There's no cure for thalassemia yet, so treatment is focused on managing the symptoms. The main treatment for these patients is red blood cell transfusions to treat the anemia, and of course, the more severe the disease, the more frequent these transfusions are going to be needed. Now, as we talked about a few minutes ago, a consequence of these frequent red blood cell transfusions is iron overload and secondary hemochromatosis, so some patients may need therapy with iron chelators to remove the excess iron. And then finally, in some cases where hemolysis is really severe, a splenectomy is done to remove the patient's spleen surgically to prevent it from causing any further hemolysis. Okay, so we wrapped up thalassemia, so let's check in with our table one final time and fill in thalassemia here. So the problem, the cause of anemia, is a decrease in one of the globin chains, and the mechanism is an autosomal recessive mutation in either the alpha or the beta gene for that chain. Okay, so let's recap what we learned today. Microcytic anemia is any anemia with the MCV less than 80 femtoliters. The mechanism is always a decrease in hemoglobin production. You can remember the causes by the mnemonic tails, which is thalassemia, anemia of chronic disease, iron deficiency anemia, lead toxicity, and sideroblastic anemia. Remember that anemia of chronic disease and iron deficiency anemia can also cause normocytic anemia in addition to microcytic anemia. Whenever you make a diagnosis of microcytic anemia, the next step is to do iron studies, because that's going to help you differentiate between these causes. Okay, that's it, and that's all. For your next video to watch, I've linked the iron studies video here that I mentioned earlier on that you can check out if you want to learn more about iron studies. And if you're done with microcytic anemia and you want to learn about the macrocytic and normocytic anemias, you can also click the links here. I hope you guys enjoyed this video. Don't forget to like, comment, and share it with others, and subscribe to this channel so you don't miss out on upcoming content. But for now, thanks for watching, and I'll see you next time.